Good afternoon, dear audience. In the next few minutes, I am going to talk about the diagnostic and therapeutic options in sepsis and trauma-associated coagulopathy. My name is Tímea Mátyási-Dombi. I'm a first-year PhD student and a specialist in anesthesia and intensive care, currently working in Manningerjenő Trauma Center, Budapest. My vision is to see efficient hemostasis management worldwide. Therefore, I would like to improve personalized hemostasis management for critically ill patients. Currently, I have two ongoing projects. Both of them use the method of meta-analysis. First, I investigate the efficacy and safety profile of thrombomodulin in sepsis-associated coagulopathy. Sepsis disrupts the balance of hemostasis, causing coagulopathy in up to half of septic patients. This leads to formulating microthrombi, leading to different organ dysfunctions and even deaths in every second case. Thrombomodulin is an anticoagulant agent with anti-inflammatory and anti-fibrinolytic properties, so it can be a possible therapy for sepsis. However, the recent sepsis guidelines are controversial. While the latest Japanese sepsis guideline recommends using thrombomodulin, the International Survival Sepsis Campaign guideline does not include it. So we aim to investigate the possible clinical benefits of thrombomodulin in treating sepsis-associated coagulopathy. This led us to our clinical question: does thrombomodulin therapy improve the survival rate of patients with sepsis-associated coagulopathy? We compared thrombomodulin therapy to standard of care. Our primary measured outcome was mortality, with different secondary outcomes like the resolution of coagulopathy, organ dysfunction, and bleeding complications. This is our search key. After the selection process, we had 34 eligible articles for our study. In the next few minutes, I would like to present our results. The first investigated outcome was 28-day mortality with over 8,000 patients. We analyzed non-randomized observational studies, propensity score match studies, and RCTs collectively and separately as well. The intervention was thrombomodulin, while the control group didn't receive thrombomodulin. The overall effect in the investigated studies was 0.65, which means that the odds ratio of death decreased by 1/3 in this examined population. This result is clinically and statistically significant. The strongest effect was in the observational group, where this decrease was 50%. In propensity score matched and randomized RCTs, this decline was around 30% and 15%, which were not statistically significant, but there was a strong tendency in these latter two groups as well to reduce mortality. We could analyze intensive care unit mortality as well. The odds ratio of deaths decreased to almost half in critically ill patients, which was a statistically significant and clinically relevant result. The next outcome we investigated was the resolution of coagulopathy. The coagulopathy scores can be quantify the severity of coagulopathy. We used the GAAM DIC score range for our investigation. As you can see in this forest plot, there were no significant difference in baseline DIC scores between the groups. But on day 7, we see that in the thrombomodulin group, DIC score was 1 point lower in the thrombomodulin group, which is statistically significant. To see its clinical relevance, we can translate it in this forest plot that this 1 point meant clinically the resolution of coagulopathy. And we can say that the odds ratio of coagulopathy resolution was 4 times higher in the thrombomodulin group than in the control group. It is also mathematically and clinically significant because after coagulopathy resolution, we can expect the improvement of organ functions. And this leads us to SOFA score. As you can see in this picture, the SOFA score enables physicians to assess organ dysfunctions. The more points means the more severe organ dysfunctions, and it means also the higher probability to increase mortality. There were no significant difference in organ dysfunction between the two groups, but on day 7, we can see that SOFA score was 1.3 points lower in the intervention group than control group, and it is also a significant result. To assess a specific organ dysfunction, we measured ventilator-free days within 28 days. You can see that the mechanical ventilation was more than one and a half days shorter in thrombomodulin group than in control group. And it has not just statistical significance, but it has a high clinical relevance as the shorter mechanical ventilation leads to less complication, for example, infection. Our last outcome is a safety outcome. It's the bleeding rate. You can see that there were no difference in bleeding rate between the two groups. So we consider thrombomodulin therapy safe. Our study has strengths that RCTs and non-randomized studies were evaluated together and separately, and we had more than 8,000 patients for primary outcome. However, the limited number of RCTs, the mostly Japanese studies, and the potential overlap of patients in registry analysis limit our result. We can conclude that thrombomodulin therapy with the resolution of coagulopathy leads to better organ functions and reduced mortality in septic coagulopathy patients. So our implication for practice is that maybe we should refine guidelines for thrombomodulin use in septic coagulopathy. And for further research, we plan to evaluate a multicenter RCT in a specific patient population. This is my first progress. Currently, I'm working with the risk of bias assessment. My second project is about the efficacy and safety profile of fibrinogen supplementation in patients with severe trauma. Trauma-associated hemorrhage accounts for 40% of all trauma deaths, and it can be worsened by trauma-induced coagulopathy, which prevalence is around 30%. Both the consumption of fibrinogen and the increased fibrinolysis lead to the rapid loss of fibrinogen in these patients, causing different organ dysfunctions and even deaths. The latest European trauma guideline says that fibrinogen levels should be maintained at above 1.5 grams per liter in severe trauma patients. We use widely fibrinogen for these patients, but we are unsure about the exact dosage and the timing of this therapy. We have a chance to give patients fibrinogen even in the ambulance or in the trauma field. So we aim to investigate the potential benefit of early administration of fibrinogen in patients with severe trauma. This is our PICO. We would like to see mortality outcomes and different clinical bleeding complications, transfusion requirements, and other thromboembolic events. This is our preliminary search. We are checking the topic's feasibility before registering Prospero. I want to continue with my 2 projects and finish the first one by December 2024. And I would like to end my presentation with the words of Tivadar Csontváry Koszka: every person needs a broader perspective to see more and to be aware of the divine nature. In a broader perspective, we want a new perspective. In a new perspective, we want a new life. Thank you for your attention.
Thank you very much, Tímea, for your fantastic talk. I have a question regarding your first project. As you mentioned in the limitations, most studies were from Japan. And as I think, or I'm not sure of the evidence, but Japanese population is a little different from, say, Caucasian or European population regarding coagulopathy. Isn't this biasing your results or the applicability for general population or European population?
That's why we need more RCTs and see thrombomodulins effect in different populations. Actually, there are some studies that say that the Asian people have a higher risk for hemorrhage and a lower risk for thromboembolic event. And if we say that, it's even more shocking that the Japanese find in their studies that thrombomodulin is better and not the European ones. That's why I think we need more RCTs for multi-center studies in Europe, America, Asia, and so on, because we have to check specific populations as well. Okay.
Are there any RCTs ongoing you know about? I mean, you have checked maybe?
No, currently not.
Because the results are overwhelming.
Yes, yes.
I would say so. It would be interesting.
Yeah,
to
unfortunately not, but I hope there will be
okay,
soon.
Thank you. One little remark to your second project. In the first slide, you showed that the risk for death in trauma is 40% bleeding, but you cited an article from 1995.
Yeah,
I hope we have some improvement in the last 30 years to this 40%.
Yeah, actually, there is some improvement, but it is...
it's still significant.
It's still
definitely.
significant, yes.
Thank you.
Congratulations to your presentation. I'm curious, what is the practice at your clinic? Do you use this thrombomodulin every day? Or?
Unfortunately, in Hungary, it is not available, so we can't use it.
Oh, I see. And is it undergoing the process? So will it become available, or you don't?
Currently not. So it's not in the process, but we hope that with these multi-center studies and with more evidence, we can use it as well here in Hungary.
Hopefully. Thank you.
Thanks.
Congratulations. My question is, if I remember well, you have 2 groups at bleeding rate outcome. What's the reason?
Yes. Can I get back the forest plot of this bleeding rate? So this is the current forest plot. We had 2 groups for a follow-up of 7 days and over 7 days, because thrombomodulin therapy usually ongoing for 6 days. So that's why we had these 2 groups, because we try to investigate whether during this therapy or after the therapy is there difference, but actually we couldn't see any difference in any of the groups. So it's safe. Thanks.